Hello and hello. Let's talk about an article tonight, 8 o'clock. I'll wait till I see a few more people online. Right now it's showing me one person is viewing. Let's wait and see. We got 4. As soon as I get to, I'll say 6, I'll start. We're at 4. 2 more and I'll start. And of course, as I'm going along presenting the article, please don't hesitate to put a comment or to make a comment. All right, so we're at 8 viewers. Let's get started. So as I scheduled, this is a talk that we're going to discuss. Basically, this article here was published in Chest in 2020, and it was sort of part of a series of how I do it. And of course, I did not write it. These are the authors here. And the topic, of course, is high flow, non-invasive ventilation, and awake proning in patients with COVID-19 with respiratory failure. So this was the part of the article that I had shared. I'm just going to go full screen here. This was the part of the article that I had shared as the description that just basically describes that in this article, they're going to attempt to separate fact from fiction and perception with reality pertaining to the aerosol dispersion. There's actually only a few small comments in the article about this. They describe precautions that hospitals and healthcare providers must take to mitigate risks with these devices. Finally, they take a practical approach in describing how they use these 3 techniques, including some common indications, contraindications, and practical aspects of application. There's actually a really nice table in this paper that describes all the actions. So I've gone through and highlighted items that I'm not necessarily going to read full on. I'm just going to sort of stop and highlight some of the points here. So first off, they do mention that concerns about aerosol dispersion had led to calls for early intubation when basically in the first wave of whatever country you were in, leading many hospitals to discourage the use of non-invasive modalities. And this included non-invasive ventilation and high flow nasal cannula. So here in this article, they enumerate the indications, contraindications, and how I do it techniques in the context of the limited but emerging safety data available. And I can say after looking at this article, although it was published in 2020, not a lot has changed in terms of recommending or recommendations for how we should be managing these patients. So just a brief description. I'm sure most of you tuning in know what high flow nasal cannula is, but high flow nasal cannula refers to high flow oxygen gas heated and humidified to body conditions. What that means is that there's different temperatures we can typically set on these devices, anywhere from 31 degrees, which is typically the temperature of the skin, up to 37 degrees, which is body temperature. Some patients may find 37 degrees uncomfortable, but we typically will start at that temperature and turn it down if they complain about heat. It's delivered via nasal cannula. They're pretty wide bore nasal cannula that fit in the nose and take up, I would say, close to 50% of the nares on average in the average patient, depending on what size you put in the nares. And the maximum flow rate for delivering high flow, typically in the acute phase. So if you're weaning someone off, you may drop them down to 30 liters per minute of flow prior to transitioning them to a different device. But typically starting, you're going to start anywhere from 40 and up to 80, depending on the manufacturer. So the most common manufacturer that I'm aware of in Canada is probably the OptiFlow series of cannula, which is made by Fisher and Paykel. And that if you speak to that manufacturer, they will tell you that the limitation is 60 liters per minute of flow in order for their device to deliver the humidification that they have studied and know that their devices are effective at delivering. So if you go above that, you may just be providing suboptimal humidification to the patients. You would clearly be providing humidification, but it may be suboptimal to their standards or their specs, depending on which manufacturer you're discussing. So it has been around for as long as NIV. It was mostly being used in the neonatal population, but has really gained traction in the past 8 years or so in terms of adult non-invasive strategies. Compared with standard oxygen therapy techniques, the rate of the high flow nasal cannula, so using those flow rates of above 40, comes much closer to the patient's inspiratory rates. Therefore, it can relieve dyspnea much better. It also prevents the entrainment of room air, which can dilute the amount of oxygen you think you're delivering a patient. And they give an example here. If you have a non-rebreather mask, which we know is a reservoir and people consider it to be a high percentage of oxygen, if you have the flow set at 15 liters per minute, The reservoir bag is there and they can pull from that bag. But if their flow exceeds the flow that's sort of going into the bag, because most non-rebreather masks are actually partial rebreathers, there's still ports in case the oxygen gets disconnected. There's ports in the sides that are open now. They're not completely occluded. Some masks they are, but in the standard non-rebreather mask, they're not. And people can instill and train room air from there. So just note that the patient's inspiratory flow may entrain the oxygen being delivered. So if you think you're giving somebody, 70%, 80% FiO2, you may be giving them less depending on their demand. And then the flushing of the nasopharynx also washes out anatomical dead space, improving ventilatory efficiency. So because it's flushing out the nasal cavity, when we exhale, we fill our nasal cavity with carbon dioxide because we are exhaling it. But of course, there's still air in our upper airway that is there and does not come out of our mouth or nose. So when you inspire on your next breath, you actually rebreathe some of that carbon dioxide in. And that rebreathing, that's called anatomical dead space. It's just basically wasted ventilation. So by sticking high flow cannula in your nose, you're flushing this space out. And this, of course, improves ventilatory efficiency. And what they mean by that is when you look at some of the studies of high flow and some of the physiology studies, you see that patients will reduce their respiratory rate, reduce their minute ventilation, but have the same CO2 and pH. So it just tells you that they can slow their breathing down and breathe differently because you're actually helping them to eliminate CO2 by washing out their anatomical dead space. So by doing all of that, it contributes to the reduction in work of breathing. And the expiratory impedance that creates, so if someone has their mouth closed and they're breathing out of their nose, there's some expiratory impedance there that can amount to, in this article, they're saying about 1 centimeter water per 10 liters per minute of high flow, which again, it's going to be variable depending on the size of the cannula compared to the size of the nair, and also the flow rate you use, as it says here, per 10 liters. So generally, you're going to be seeing anywhere between 3 and, there's some articles showing up to 12 centimeters of water of pressure, but that would be very high flow with a cannula that fits most of the nose. The average pressure is typically around 3 to 4 centimeters of water. However, there is some EIT studies out there showing an increase in end expiratory lung volume when using high flow nasal cannula. So thus, high flow nasal cannula is more than just oxygen supplementation. It is a very well tolerated ventilatory assist device with multiple potential advantageous physiological attributes that is also easy and safe to apply. And this is important because when high flow nasal cannula first came out, there was kind of hesitancy to call it non-invasive, a non-invasive ventilation adjunct, because we think of ventilation as positive pressure. That's just what we're used to. But then someone on CPAP, for example, we would still call that non-invasive ventilation, but we would call it CPAP, which is just continuous pressure. There's no augmentation of inspiratory effort or inspiratory flow. So now that it's been shown to reduce respiratory rate, decrease work of breathing, et cetera, it's being more accepted into this realm of non-invasive ventilation or non-invasive respiratory support. But keep in mind, it does not augment tidal volume in the way that non-invasive does in terms of BiPAP, which is 2 levels of pressure. Of course, that helps to offload work of breathing as well. So compared with non-invasive ventilation, high flow nasal cannula is primarily a flow generator, and it is via high flow that it achieves its main beneficial effects of more reliably delivering targeted FiO2, and reducing dead space to improve ventilatory efficiency. Non-invasive ventilation, in contrast, is primarily a pressure-targeted modality, and it is pressure that is responsible for its success for its 2 main indications. So the 2 main indications for non-invasive ventilation, of course, are COPD exacerbations by counterbalancing not only intrinsic PEEP, with an extrinsic PEEP, but also providing pressure support to assist inhalation. And then, of course, acute cardiogenic pulmonary edema by applying CPAP or bilevel, there's a reduction in intubation. And these are the 2 main recommendations for non-invasive ventilation, or of course, COPD and cardiogenic pulmonary edema. So in terms of evidence of efficacy, a number of studies have compared high flow nasal cannula with non-invasive ventilation and standard oxygen therapy. High flow nasal cannula has been shown to be more comfortable and better tolerated, provides better oxygenation, et cetera, et cetera. Most studies of the randomized control trials end up using flows of around 50 liters per minute of flow. So they usually start low and then titrate up for tolerance. And then the average flow rate that's reported is typically around 50 liters per minute of flow. This is just some talk about the Florali trial, which compared high flow with a non-rebreather mask and with non-invasive ventilation. And of course, their primary outcome overall was a reduction in intubation rates, which they did not see in the overall population. But when they looked at the subgroup of patients that were more hypoxemic with PF ratio less than 200, they actually found that there was a reduction in intubation in those patients. So less patients with high flow nasal cannula were intubated than any of the other groups. And mortality overall, which was a secondary endpoint, was actually significantly less in the high flow nasal group than the other groups, likely because the avoidance of intubation in these sicker patients here. Now, having said that, there are now clinical guidelines that exist for non-invasive ventilation, or sorry, not high flow nasal cannula. There are guidelines now that exist. I will quickly look up. I'll be bringing up that other paper in just a moment. So there's the clinical practice guidelines here. There was a systematic review and meta-analysis that was published prior to this, but let me just get down to the graphic that shows the current guideline recommendations for high flow nasal cannula. When should high flow nasal cannula be used in the clinical setting? For hypoxemic respiratory failure, period. Strong recommendation. Over standard oxygen therapy, and I would say over non-invasive ventilation, particularly in patients that are de novo respiratory failure, which means they don't have underlying COPD or cardiogenic pulmonary edema. If they do, then you should choose BiPAP. If they don't have chronic underlying lung or cardiac disease, then high flow nasal cannula is the go-to. Following extubation, meaning immediately following extubation, like you extubate you pull the tube out and you put them directly on high flow nasal cannula. They have a conditional recommendation there. Post-operatively, in high risk and or obese patients following cardiac or thoracic surgery, conditional recommendation. And in the peri-intubation period, so this is basically trying to do like the prior to intubation, giving patients a high level of oxygen just to sort of prolong that apnea period in terms of keeping their saturations up. So this is applying high flow and then intubating somebody. Many people have started doing this practice, at least with nasal cannula, but they don't provide a recommendation. They don't recommend against it. They just don't feel that there's sufficient data to say that this is something that everybody should be doing, but they have sufficient data to make these recommendations here. So back to the paper. Again, if anybody has any comments as I go along, please throw them in the comments, or if you want me to stop or focus on something, then just let me know. If you want to just say hi, then say hi so I know I'm not talking to myself as well. That's always helpful. All right, so talking about the Florali trial here. So let's get down to the controversy. So some guidelines initially, when we were getting hit with COVID-19, some guidelines cautioned against the routine use of high flow nasal cannula or non-invasive ventilation, potentially because of this potential aerosol generating concern. However, the Surviving Sepsis Campaign Society of Critical Care Medicine guidelines that came out very early, although I didn't agree with all of the recommendations, in particular applying high PEEP to everybody, they did advocate for high flow nasal cannula as a first-line approach, and then a short trial of non-invasive ventilation in patients that they said was okay, but has potential risks with it. Hi, Marissa. So the contention is that failure rates, hi Yvonne, the contention is that failure rates of non-invasive ventilation approaches, I don't even want to say just with COVID-19, but failure of non-invasive ventilation for hypoxemic respiratory failure secondary to a pneumonia, which when COVID-19 patients present in hypoxemic respiratory failure, they have elements of pneumonia, and they're developing pneumonia. These patients, hold on, I know I haven't lost access to Facebook, but it's telling me to click here. 1 second, just let me click that again. There we go. These patients, when in hypoxemic respiratory failure, are at a higher risk of failing non-invasive ventilation, and this really isn't different with COVID-19. Now, when they fail, the concern is that you then have to do aerosol generating procedures that we know are risky, which is, of course, bag mask ventilation and intubation. So the contrary view is that aerosol mitigating interventions, such as the use of negative pressure rooms, high energy particulate, let's just say HEPA filters, and adequate personal protective equipment are sufficient to protect staff. So that's the contrary view. So the first view was like, don't do it, it's aerosol generating, don't do it, don't do it. And many hospitals, even in Ontario and Canada, were like, yeah, we're going to avoid both non-invasive ventilation and high flow. And then the contrary view was like, well, if you protect yourself when you're in a negative pressure room, then it should be okay. So then many people were making that as a rule that they had to be in negative pressure rooms. And we'll talk a little bit more about this in a moment, because they basically mention papers, or at least the data that's out there, and I've mentioned it a few times, that non-invasive ventilation and high-flow nasal cannula do not appear to disperse the aerosols that are there any farther than other devices like nasal cannula or a face mask. And they don't appear to generate more aerosol than what's already there. So again, important points. So avoidance of intubation might improve patient outcomes and preserve much needed critical care ventilators. And that's why many people started switching and saying, okay, well, maybe we should do these non-invasive therapies, because if we don't, we're going to run out of ICU beds, because we can do some of these therapies in other areas. And so perhaps we should do that. And then, of course, there was the concern that maybe we're intubating people too early. So there were a number of studies that examined aerosol dispersion during during the use of various aerosol generating procedures that regarding high-flow nasal cannula have been reassuring. These show a smaller distance of dispersion for high flow than for a number of other aerosol generating procedures, but because most have been performed with human mannequins with smoke or other substitute particulate, they have not universally allayed the concerns of some practitioners. A recent study suggests that a droplet surgical mask placed over the nasal interface can greatly reduce dispersion of aerosol. Another recent study of healthy volunteers showed no increase in aerosol over background in a simulated hospital room with high-flow nasal cannula, up to maximum flows of 60, compared with the use of standard nasal cannula or non-rebreather mask. So here's the point, that when they've shown aerosol, sort of background aerosol, what's the aerosol in the room, and then they generate these flows, these devices, and there's not, and again, they've had studies in healthy volunteers, as it says here, and they just have the background rate of aerosols being generated by them talking, coughing, breathing, and when they've compared it with turning these devices on, there's no increase in aerosol distribution, or sorry, aerosol generation. But of course, these devices can disperse these aerosols, and that's the concern, but not differently than standard nasal cannula or a non-rebreather mask. All right, so the next section here talks about indications and application of high-flow nasal cannula in patients with COVID-19. This is where we have a really nice graphic here, but before I get into that, I'm just going to quickly go on to talk about what Yvonne's just saying here. Let me just see here. Let's put this up. Based on the earlier comment from the study, non-invasive ventilation appeared to be a better oxygenator. You also mentioned EIT. Studies look at lung volumes. Was that in high-flow nasal cannula? Yes. So EIT was used in studies of high-flow nasal cannula that showed, because people argue that there's not much positive pressure being generated so some people argue there's not much pressure being generated by high-flow nasal cannula, therefore it's probably not doing anything. And then when they looked at it, they found that there actually was an increase in end expiratory lung volume measured by EIT when using high-flow nasal cannula. So it could help guide therapy, but it's hard to say. Those studies weren't specifically in pneumonia patients. If I'm not mistaken, they were in post-op cardiac surgery patients, which is where we got some of the recommendations from. So I don't want to say that this would be the best thing for that. I think the best criteria for deciding the timing of proning with or self-proning of high-flow nasal cannula patients would be based on their oxygenation status rather than what EIT is telling you, if that helps. All right, let's get back to here. So their nice little graph here. So they have, start off someone. So step one, if they're in no respiratory distress, if their SATs fall below 92 to 94 on room air, then you should start them on some supplemental oxygen, 4 to 6 liters per minute. If they get worse, then you go right to oxygenation strategies. So if you can't maintain this, you're going to go right into the non-invasive ventilation strategies here. So what did they recommend? They recommend this for patients with a PF ratio greater than 150 and less than 300 with SATs less than or equal to 94 on a non-rebreather mask and or labored breathing. So basically, you don't hesitate, you throw them on a non-rebreather, and then you're like, okay, they need other support. So high-flow nasal cannula is the preferred modality here. Minimal hypercapnia. So if your patient's CO2 is not an issue, great. Let's jump over here for a moment. It says non-invasive ventilation. Now, it does say consider helmet. This is simply because we have some data that you can generate higher levels of CPAP with a helmet than you can with a face mask, for example, at least better tolerated. Having said that, not everybody has it, and it's not So like I said, not everybody has it. It's not the most common therapy that's used in many hospitals because of that reason. A, because they don't have it, and B, it hasn't really been promoted a whole lot until really COVID-19. But if you had a helmet, then you would probably prefer to try that. Now, it does say you would do this in patients with COPD with moderate hypercapnia or cardiogenic pulmonary edema or inability to carry out worker breathing, and of course, if they have a low aspiration risk. So otherwise, this is the preferred modality unless they have, again, the two conditions that are the most common use for non-invasive ventilation, which is COPD or cardiogenic pulmonary edema. Then you would understand the fact that there's probably going to be some benefit to providing the therapy we know already helps these patients, even if they present with a pneumonia. And actually, there is some data to support that. If you give non-invasive ventilation to patients with community-acquired pneumonia, for example, the patients that don't have COPD or cardiogenic pulmonary edema, it does not reduce intubation in those patients, but in patients with this, it actually does reduce intubation, even if the admission diagnosis was community-acquired pneumonia. So that evidence exists. So finally, step 3, severe respiratory distress. What do they consider that? A PF ratio less than 150, it says, or a SAT divided by PO2 190. I'm not familiar with this parameter. I feel if you have a PaO2, then you should just calculate your PF ratio. We understand that. We've been using that for ARDS research for years. And I'm not 100%, I'm assuming they got this correct, but I was expecting maybe something like SATs divided by FiO2, which is what you would do if you were not in an area that had the ability to analyze blood work. So I don't think this is a typo, but I'm not familiar with people using this very often. Someone can correct me in the comments if they know of a study that used that. I know ones that have used SpO2 divided by FiO2 as a surrogate for PF ratio in developing countries, for example, that may not have access to blood gas analysis routinely. And of course, if your patient's hemodynamically unstable or risk of impending respiratory arrest. And then invasive ventilation, it basically says, unless they carry a DNI order, then you would just start with the typical ARDSNet guidelines. Having said that, when you say start with ARDSNet guidelines, where you set your PEEP is they're not recommending which table you use here, which was recommended in the initial guidelines from the Society of Critical Care Medicine. And then many people sort of started to refute that recommendation that everyone should get high levels of PEEP. Anyways, let's move on. High flow nasal cannula failure. The greatest danger when using high flow, and I would say also with non-invasive ventilation, is that if you fail to monitor closely enough, you can have an unanticipated need for intubation, meaning you're not prepared, you're not ready for this to happen. And this, of course, has an increased risk of airfall exposure to the intubating team because now you're coming in urgently, right? Anytime we have to intubate a patient, if they're in isolation, there's a delay between us getting in the room and intubating them and them just basically not breathing. So it's important that you kind of want to have an understanding or, again, some foresight that this patient's probably going to need intubation. Therefore, you don't want to delay intubation and then do it urgently when someone's obviously isolated, because there's obviously a huge risk of exposing the entire team that goes into the room. And of course, the fact that the patient is not able to get as speedy of help when everyone has to gown, glove, get all their gear, etc. So I mentioned some of the physiological effects. I won't go into them again, but in terms of awake proning, I'm going to use these tables here to talk about awake proning. So it can reduce alveolar overdistension in the non-dependent areas, as well as collapse of alveoli in dependent areas. Why? Because you put the people on their belly, and now they have free rein to expand their dorsal lung regions. There's less compression of dorsal lung units with the maintenance of dorsal perfusion, and improves VQ matching. So what's interesting is in studies that have measured perfusion in patients that are supine and prone, perfusion actually doesn't change significantly when you put someone in the prone position. Perfusion does not change. What changes drastically is the ventilation distribution. So when it says you improve your VQ matching, it's mostly through the action of improving ventilation than it is improving perfusion. You just have a better matching because now you have more lung tissue, and that lung tissue has a lot of perfusion there already. So you don't increase perfusion there. You just say, hey, where do you have most perfusion in your lung? It's in the dorsal lung regions. Where do you have the most lung tissue? It's in the dorsal lung regions. If you can better match those regions, your VQ improves. And this also can facilitate drainage of respiratory secretions from the dorsal lung regions. I think we can all attest to that in patients that are intubated. When you put them prone, some of these patients you're suctioning for the next 15 to 20 minutes. Just drinking some coffee, pardon me. Yes, I know it's 8:30. Indications. So I talked about some of the indications, but basically respiratory failure, first line treatment if simple O2 supplementation is insufficient. They also recommend it in post-extubation patients after prolonged bouts of invasive mechanical ventilation. If weakness is profound, alternate non-invasive with high flow every couple of hours. So if you have a patient who's been on the ventilator for a long time, you're going to extubate them. They are at high risk of extubation failure, and they're recommending alternating things like high flow and non-invasive. Non-invasive for better ventilatory assist, and high flow nasal cannula for better tolerance and humidification. Over here, indications, again, may use alone or in combination with high flow or NIV in terms of awake proning. And then over here, you can use this is non-invasive ventilation, use it, of course, in patients that meet the most strong evidence we have, COPD, cardiogenic pulmonary edema. And then post-extubation, some indications for incipient respiratory failure, again, often combined with high flow nasal cannula in this patient population. Precautions, very rarely patients may not tolerate high flow nasal cannula. It's very rare. If they're not tolerating it, it could be one of two things. It could be the temperature setting. So if you have it set at 37, consider turning it down, but ask them, is this too hot? They might say yes. Also, the flow rates. At high flow rates of 60 liters per minute, patients with a high inspiratory demand may not be bothered by it, but someone who's not yet at the point of a high inspiratory demand may really find 60 liters per minute really irritating. I've worn 60 liters per minute in a study and it sucked. But mind you, I was not in respiratory distress. I was a healthy volunteer. Some patients develop facial abrasions from self-proning just due to the cannula. Of course, you would have the same issue if you were wearing a non-invasive mask, for example. And then they recommend, in terms of precautions, to monitor the ROX index, which I will talk about in a minute, but it's basically saying at 12 hours, a ROX score less than 3.85 may predict failure of high flow nasal cannula. So if you are at 12 hours and you measure their SpO2 divided by FiO2, and you take that number and divide it by the respiratory rate, if the number is 3.85 or less at 12 hours, this may predict failure of high flow nasal cannula. Therefore, you may want to decide whether or not it seems reasonable to consider intubation in that patient. I'm not saying it's an absolute. In this study particularly was not COVID-19. I'm going to show a couple of papers that did look at the ROX index in COVID-19 patients, but 3.85 was for pneumonia patients. In the ROX index study, it was patients hypoxemic failure that the cause was pneumonia. But yeah, they had 3.85 for failure. Most of the scores you see for the ROX index are predicting of success. So a number higher than a certain number predicts success. In this study, it was 4.88 or higher predicted success. So obviously there's a gray area between 3.85 and 4.88 where you're not quite sure what's going to happen to that patient. In terms of precautions with proning, use pillows under major pressure points, particularly the waist, and some people will really appreciate them under the shoulders, but of course they're going to want the head to be comfortable. After proning, copious secretions may drain. Patients with fresh tracheostomy, anterior chest wall thoracostomy tubes, hemoptysis, blah, 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 et cetera, should generally not be placed in the prone position, but people have been pretty creative with tracheostomies. I think the key word here is fresh. You just really want to make sure you don't lose a fresh tracheostomy when you're in the process of proning somebody. In terms of non-invasive ventilation with helmet or face mask, some patients are, they complain of claustrophobia. There's an aspiration risk because their mouth and nose are covered if you're using a normal face mask. Continued recruitment of accessory muscles, which may diminish someone's own demand to use their muscles. So, for example, I'll give you a quick, short little story of a patient I saw. This was years ago. This was probably 2007. Yes, because I know what hospital I worked at, and I was not yet in a leadership position. I was bedside RT, and I went to see a patient who was on BiPAP, and he was a known COPD patient, severe COPD. You could argue end-stage COPD. Was on BiPAP, and I walked in the room, and he was sleeping. He was comfortable breathing, and his wife was there, and I asked his wife, I said, And I said, "Hi, how are you?" She's like, "I'm great." And I said, "Yeah, your husband looks quite comfortable." And she goes, "Oh, he hasn't looked this comfortable in 10 years." And I thought, "Oh, okay. Well, I'm going to go turn his settings down," which might sound crazy to someone who doesn't practice respiratory therapy. But the whole point is you're trying to get someone back to their baseline so that they can go home and get out of hospital. If you're relieving so much work of breathing that accessory muscles that they're used to using for the last 10 years in order to function normally in their daily life, if you are eliminating the need for them to do that, you're not doing them any favors getting them back to their normal function. So unless they want to stay all the time on this BiPAP. So I went ahead and turned the settings down to allow the patient to do a bit more work. And he was on quite high settings that just, again, this was my first time seeing him for the day. But that's a little side note there. So yeah, if your patient looks, if a family member ever says the patient looks better than they've looked in years, you can probably go ahead and wean if they're breathing spontaneously, of course. If they're heavily sedated, that's a different story. This patient was not. Anyways, generation of excessive tidal volume should be limited. Now, there is a study that shows tidal volumes greater than 9 mils per kilo of predicted body weight are predictive of failure, but I want to caution people that that study was done using a non-invasive ventilator that was able to monitor exhaled tidal volume. So it's not the single limb use that we're used to seeing with, for example, with the Philips Respironics devices like the V60. It wasn't a single limb circuit. It was a dual limb circuit. So they were monitoring exhaled gas out of a ventilator circuit. So just know that. And then in patients with PF ratio less than 150, NIV may be associated with increased mortality compared to invasive ventilation. And this is true, and I'll bring up this point again later because I've highlighted it later in the document. Technique, again, just making sure you're in a properly ventilated room. If you have a negative pressure room, it says if available. If not, hopefully a room with at least 6, preferably 12 air exchanges per hour. This would be whether or not your hospital has that. Fit nasal prongs using fitting guides as per manufacturer. Most manufacturers, well, at least Fisher and Paykel, for example, will just say, they used to say 50% of your nares, and then they found that people were being way too picky with that and like getting out rulers. And they said, and then I think they changed it to mind the gap. Just make sure that you're not occluding the nasal cannula or the nasal space. So just don't occlude the nares with your cannula. Strap on firmly, but not too tightly to nostrils. Initiate the flow near maximum for manufacturer setting. So depending on the manufacturer's setting, you're going to start at least 50. I generally like to start somebody, when I first turn it on, I'll start to 40, get it on. It's on there nice and secure. I immediately turn it up to 50 and ask them how that feels. And if they seem not bothered by it at all, or they have a high demand, I will go up to 60 before I leave the bedside. If I go up to 60, I will generally wait a few minutes and ask them how that feels, because you don't want to leave the room and then have them rip it off. So really try to convince them that this is helping, that the flow will help them to relieve work of breathing. But if they're completely annoyed by the flow or the temperature, again, this is not a therapy you slap on and leave right away, because you will be back in that room if you do. So just keep that all in mind. Now, what they recommend also is place a droplet mask over the nose and nasal interface to reduce aerosol dispersion. And people can make a comment in the chat if you're still listening, if you've done that. I know we've placed masks on patients. Of course, they're allowed to take them off if they're eating, etc. But this is a pretty common practice, I think, particularly if you're transporting a patient. But even within the ICU, if you're going to go into the room, it does help to eliminate some of the aerosols in the room. We had a patient who was on high flow for a while, and he was very compliant with that. He was actually very, very worried about where he might end up. He was worried he might be intubated. He wore the mask religiously while in the room to protect us when we came into the room, because we're wearing PPE, but really you're walking into a room full of COVID if the person's in there coughing away for an hour or two, or all day for that matter. So start at 37 degrees and adjust down if the patient needs it for better tolerance, which I already mentioned. Monitor respiratory rate and breathing patterns. This is monitoring. Let me go back over to here. Technique. Just make sure you have resuscitation equipment available, and basically just making sure that your IVs aren't getting yanked or pulled in different directions. I think most people understand how to prone a patient, but many patients, you don't have to help them prone. Many patients, you just say, hey, can you lie on your belly? And they're able to do it. The elderly or weak patients that cannot do that obviously may need some assistance. And of course, you'd want to make sure you get the right number of healthcare providers in the room to help you to do that. Otherwise, instructing the patient to do it is usually sufficient if the patient is otherwise able to do so. For non-invasive ventilation, it's saying use a negative pressure room, full PPE, N95 masks, etc. Use helmet if feasible, or oral nasal masks, again, covering the nose and the mouth. Use ICU ventilator and with a dual circuit if available. Again, one of the reasons is, yes, you can filter the expiratory limb. There's no leak. However, most manufacturers now have a leak, what's called a disposable exhalation port. They now have a filtered exhalation port that you can stick a filter on. So the whole point of the dual limb is that you can filter it, but you can also monitor tidal volume, which was done in a study, and they found that it was predictive of failure. And of course, if you're applying this, you want to know whether or not your patient's going to be successful or not. So it says initiate CPAP and a pressure support of 15 and titrate until the respiratory rate is below 20 if possible, FiO2 at 100, and titrate down to maintain SATs greater than 92. Monitor respiratory rate and breathing pattern. They say check the ABG within a half an hour. Later on in this article, they say 1 to 2 hours after initiation of these therapies is very crucial. And I would agree. I generally recommend 1 hour reevaluation of these patients. They're saying check ABG in half an hour. I say by the time you're finished messing around in that room and get out, I don't think you want to come back in the room in half an hour. So 1 hour is probably better, provided, of course, your patient is tolerating it. Proning, again, note those patients who show an improvement in the first, so those who show an improvement typically do so within the first 2 hours. So if your patient's been lying on their belly for 3 hours with no improvement, it's questionable whether or not it's helping them, but obviously you're going to always closely monitor the patients. For non-invasive ventilation, watch respiratory rate, check your ABG, watch for improvements in SATs and lowering respiratory rate. Again, you want to see that the patient's not being stabilized in their respiratory failure condition. You want them to be improving in their respiratory failure condition. So you're looking for signs of improvement, not signs of stability. They can be stable once they've improved, but that's my point, is that you want to see an improvement and then they stay in that improved state. You don't want to put BiPAP on someone breathing 34 breaths per minute and you put it on and they're still breathing 34 breaths per minute. When you leave and 10 minutes later, they're still breathing 30 or more than 30 breaths per minute. This is not someone who's improving. Okay, so let's just skip ahead here. Watch out for climbing PCO2 in patients. They talk about this ROX index. Let me quickly just skip over here to the ROX index. So there was a paper called an index combining respiratory rate and oxygenation to predict outcome in nasal high flow therapy. I mentioned the 4.88 cutoff. Let me just scroll down to some of the graphs here. Again, it's telling me I lost connection to Facebook, but it said that yesterday and I did not. So let's go down. So when they look at, they basically looked at how well the ROX index compared to other elements. Let's go down to here. Here we go. So they found, now you have to understand when something is predicting something, it's either predicting success or failure. And this is important for understanding what sensitivity means and what specificity means, because if you're predicting success, it means something different than predicting failure. So in this example, 4.88 is predicting success. Okay. Now the sensitivity and specificity is not actually that high for either of these. They're pretty equal here at 2 hours. At 6 hours, the sensitivity increases. At 12 hours, it increases more. 18 hours, 24 hours. So you can see over time, this increases in sensitivity. So what that means, it's properly identifying patients. So there's no false negatives. The people are mostly that are, so 89% of the people are correctly identified as successful. Now the specificity getting lower and lower means there are some false positives, meaning there will be people failing that are above that. You just need to understand that. So yes, it will correctly identify, but it's going to overdiagnose people. So you're going to have people that are above this level, but will still fail. So again, since specificity being low means there's a lot of false positives. So people that are above this are actually not okay and they will fail. So this does not mean you stop monitoring. If you want the levels with the highest specificity, I believe a ROX index around 8 or 10. I think 10 at 12 hours or so, if I'm not mistaken. But anyways, once you get to like 8 and 10, if your ROX index is 12, I'd be like, okay, this patient's really good. But in terms of 4.88, it's better it's not that good at, again, there's lots of false positives here. So what else did they do? They had another table in the supplemental data, which had 3 other values. And one of them was, let me see if the table, I don't even think the graph is here, is it? No. So let me look at the numbers. Pardon my scrolling for a moment. I know the numbers are in here because it's the graph that I like the most. Variables. I think it was in the abstract, so let me go back up here. Here we go. A ROX index less than 2.85. So again, now we're talking less than, they're predicting failure now, okay? So this is important for sensitivities and specificities now. They're talking about failure. A ROX index less than 2.5, less than 3.47, and less than 3.85 at 2, 6, and 12 hours of high flow initiation, respectively, were predictors of high flow nasal cannula failure, okay? Now, let me try to find this in the article, because I'll show you the sensitivities for that if I can find them. Yes, there's a gray zone. Actually, they may just say that they use the highest specificities, which they did. So I mentioned in this other paper that we were discussing already, this one here, they talk about 3.85 had nearly 100% specificity. I believe it's like 99.2 or something like that. What that means is that when you're predicting failure, if you had false positives, so specificity, if it was low, you mean to have false positive. If it's 100%, you have no false positives. You do not want to identify someone as failing if they're not going to fail, because what's the consequence of someone failing? You would intubate them, right? So if you're predicting failure, the response would be, my patient's going to fail, therefore I'm going to intubate them now before they fail. So if you want to make that decision, you want absolutely sure that you do not have any false positives. You don't want to intubate people who would otherwise have succeeded. So that's why they have these other thresholds. These thresholds are like, listen, if you want a value to predict success, here's one number. But if you really want to know if someone's going to fail and you want to be able to make some more solid decisions, perhaps, a ROX index less than 3.85 or equal to 3.85 at 12 hours was highly predictive of failure. And the likelihood ratios were very, very high for that as well. And all that data is in the supplemental table of the ROX index study. And then I'm going to show you, at the end of this, I'm going to show you, there's an online presentation that you can register for and watch. It's by Philips. I did a presentation. I was invited to give a presentation for Philips on this topic. My moderator was Dean Hess, who was a RT PhD. Many people know Dean Hess. He was the moderator. We had a good discussion at the end of the presentation, and it is free to view online. You just have to register in order to see it. There's a checkbox whether or not you want to receive notifications of future events, whatever. You can deal with that if you don't want to do it or not. So let's scroll down here. A little bit about the safety and precautions. I mentioned on the basis of recent review of the literature on maximum exhaled air dispersion via different oxygen administration and ventilatory support strategies, we have concluded that CPAP via oral nasal mask and NIV via helmet with an inflatable neck cushion are the ventilatory support methods that allow minimum room air contaminations less than every other oxygen delivery system. So keeping in mind that high flow nasal cannula and nasal prongs and non-rebreather masks are all very similar in their dispersion of aerosols. So be careful no matter what therapy your patient is on. Indications, the most recent European Respiratory Society and ATS guidelines make no recommendation for the use of NIV during a pandemic due to insufficient data. There is some data that came out of China showing that there was not an increased risk of transmission when people wore proper PPE, but there was a study, I believe, out of Toronto that showed that this was how it was transmitted, but people weren't wearing proper PPE. So you can't really, it's hard to draw conclusions, which is why they don't have a recommendation. So further research is recommended or is needed to really solidify that. But right now there is no recommendation, not for or against the use of non-invasive ventilation during a pandemic. At the time of SARS, which is when these papers were published that they're referring to, we didn't have a common use of high flow nasal cannula in adult patients. So let's scroll along here. I highlighted a bunch of stuff, but I don't think it's adding to what I'm saying. They do say here that in conclusion, a cautious non-invasive trial may be indicated in a subset of patients with mild to moderate acute respiratory failure. The bottom line is a PF ratio less than 150. Oh yeah, this is a good paragraph here. So in an observational study of 459 ICU patients from 50 countries, Giacomo Bellani was the author of a study called the Lung Safe Study, and it is the largest epidemiology study that was done in ARDS patients. And they demonstrated that non-invasive ventilation, despite having no recommendation for hypoxemic failure, it was actually used in real life situations in about 15% of patients with ARDS, irrespective of severity of disease. So this included patients with severe and moderate ARDS. However, non-invasive ventilation was associated with a higher ICU mortality in patients with a PF ratio less than 150 when they compared them to patients that were just intubated. So if you're keeping someone on non-invasive ventilation for long periods of time, their PF ratio is still less than 150. The evidence suggests that they would have better outcomes if you just intubated them. So again, that's based on observational data, 459 ICUs across the world in 50 countries. So this is why they come to this. Observing patients for 1 to 2 hours after NIV is important. Any sign of increasing respiratory rate or recruitment of accessory muscles would indicate high worker breathing and suggesting the need for intubation. So use a very cautious approach to trialing NIV. And with mild to moderate acute respiratory failure, again, this PF ratio is in the middle of moderate ARDS. So that's why that says minimum to moderate. Respiratory failure, they're probably referring to something like a PF ratio. In terms of proning, how long? Some studies use 3 hours, some use, so 3 hours, 2 hours. We know that, that what we do when they're intubated is we go 16 hours a day, but maybe not all patients will actually tolerate lying on their tummy for that long. There are no formal guidelines for proning non-intubated patients. However, protocolizing it will probably lead to better compliance, not only with your staff, but also with patients. Much like what we've done with proning intubated ARDS patients, we all have protocols now. We're very structured, and this helps not only with staff comfort, but also with I think the success of proning and the safety of it. So although the development of pressure ulcers is unlikely in the awake prone patient, provision of appropriate padding to pressure points such as shoulders and knees should be considered. Judicious use of pillows positioned under the pelvis may be useful. Finally, the improvement in oxygenation may be transient or lead to a false sense of security, delaying potential life-saving conversion to invasive mechanical ventilation. All right, so I won't read the conclusion because it's just probably pretty much going to summarize everything I just talked about for the last 47 minutes. So let's get to some questions. I see one sitting there. I'm just going to put this back up here, bring myself back on screen. And I wanted to show a couple more things. Let's show this first. This is a nice graphic. This is by Dr. Ewan Gallagher and Dr. Arthur Slutsky. This was a letter. It was an editorial for a paper that was published in the Blue Journal. I don't know where the word Jew came out. I'm looking at this and I'm like, the Blue Journal. So the American Journal of Respiratory and Critical Care Medicine. And they have this really nice graphic showing all of the main mechanisms by which it is understood high flow nasal cannula helps. So heated humidification of inhaled gas, washout of upper airways, reducing nasal inspiratory flow. If you think about it, when you're inspiring, the reason why patients open their mouth is because they're trying to inspire rapidly through the little holes that we call nares. So delivering high flow past that point reduces nasal resistance, which would would improve dynamic compliance. So it would reduce your resistive pressure, which would increase your dynamic compliance. And this all, they think, helps provide this mechanism for decreasing inspiratory effort and workload, decreasing respiratory rate and minute ventilation requirements. Again, by washing out the dead space, like all this stuff is in here. A little bit of positive pressure and the less entraining of ambient air, again, because the flows are hopefully meeting the inspiratory demand of the patient. I mentioned the ROX index. There's a couple other. There's a research letter that looked at predicting outcomes of nasal high flow in COVID-19 patients. Understand that the median time to intubation in this study was 10 hours. They found that a ROX index after 4 hours so the ROX index at 4 hours demonstrated a good discrimination. The area under the curve is 0.75, which is acceptable. Sensitivity 66, specificity 83. So not that many false positives. And they found the level of 5.37 was their threshold for predicting success. This study here, this is a research article published in BMC Pulmonary Medicine. And they looked at the ROX index at 6 hours after initiation of high flow, and greater than 5.55 was significantly associated with high flow success. So again, monitoring early and really looking at this to really pay attention to the risk your patient may have of failure. Finally, before I get talking and answering questions, which I'm already jumping all over the place, this is the one I told you about. This is the online presentation that you can register for and view that I did with Dean Hess. I'll put a link in the chat. Better Outcomes is the website, so it's better-org/HF-therapy or -therapy, so high flow -therapy. And this is high flow therapy and non-invasive ventilation in COVID-19 patients. The learning objectives is here, my bio, blah, blah, blah. You basically just put in your name and it says, I would like to receive marketing related electronic communications about Philips products. You can say yes or leave it blank. And when you click register, basically, once you get this information, it says, thank you for registering. Once you fill in this registration form, you will be redirected to the on-demand webinar. So you can watch it whenever you want. Okay, let's go back to the screen and let's answer a question. Do you have recommendations for weaning high flow nasal cannula when patients improve? My first thing, and people can comment on their own hospital policies because I don't really actually know my own hospital policy. I just know, like, I think more physiologically than anything. So for me, I consider high flow nasal cannula doing two things. I consider it providing oxygen and reducing worker breathing and respiratory rate. So once my oxygen is no longer a concern, then I will start with the flow. So first things first, getting oxygenation down. So I would like to have my patient comfortable on 30% FiO2, although 40 is sufficient. Again, less than 50 and I'm happy, but ideally if they're on 30, I'm feeling pretty darn good about transitioning them over. If they're on 40, I'll have them on 40% FiO2, and then I will start to see if I can reduce the flow and they can maintain oxygenation. If they don't maintain oxygenation, it's likely because worker breathing is slightly increasing. And when worker breathing increases, there's a cost to that, and that cost, of course, is oxygenation. So I would get FiO2 down to 40% or less. And then I would reduce the flow. How quickly you should reduce the flow? If you're on 60 liters per minute of flow, I probably would be pretty aggressive and just get them down to the lower limit of acute failure. So if they don't appear to be an acute failure anymore, go from 60 down to 40. If they tolerate that, 40 is still like starting point for acute failure. My next step would be down to 30 liters per minute of flow. Once they can tolerate 30 liters per minute of flow, I would see if they can tolerate coming off to a different oxygenation device. But if you can't get them below 40, if 40 is actually reducing worker breathing and helping maintain oxygenation, then I probably wouldn't take them off yet. Again, other people may disagree or have different hospital policies, but typically I think getting them down to 40 of liters per minute of flow and at least 40% oxygen or less, and then see if I can transition them to 30 and off. So if they tolerate 30, great, I'll take them off. If they don't tolerate 30, I'll put them back on 40 and try again tomorrow. And I'm talking about liters per minute of flow in that time. I know it's, both my examples are 40 and 30, so I apologize. So just remember 40 and 30. Try to get them to 30% FiO2, but 40 is okay. And then get them to 40 liters per minute of flow and then try 30. And if they tolerate that, then you can try tolerating or try transitioning them away from it. People may suggest other things that they have found successful for themselves. By all means, put them in the chat. Or maybe you agree with that or do something slightly different. By all means, say what you'd like. Enter here. We have 6 minutes left. I'm going to try to keep this one to an hour since I had to very structured idea of what I wanted to talk about. So although I'm planning 1 hour, I think everybody knows that I could be swayed otherwise. Yeah, so I think a lot of people have a protocol for setting it up, but then turning it off is a little bit sort of a trial and error, I guess. But I think it's a reasonable approach, and I think most people probably do this, is wean FiO2 first. I think that makes the most sense, because we have to consider what the flow is doing. The flow is obviously doing other mechanisms such as reducing work of breathing, reducing anatomical dead space, etc. So once the FiO2 is not a concern, you have only one thing to worry about, and that's the flow. And basically, if I can get them to 30, I'll take them off. But if they don't tolerate 30, I will leave them on 40 at minimum, if you can get to 40. I mean, if you go from 60 to 40 and they don't tolerate that, then I maybe would go to 50. Actually, if they looked fantastic on 60 and they don't look good on 40, or they start to desaturate on 40, then I would meet them halfway. But that's why I'm usually aggressive like that. I'll go from 6, like I'll be aggressive in my first wean. If they don't tolerate it, I'll meet it halfway. I'll compromise. Any more questions? Again, you don't have to ask me a question about the article if you don't want. I'll talk about anything. Oh, Ariel, you're working, man. What are you doing? Don't you have patients to look after? Can you clarify again the driving pressure values when you recognize airway opening versus when you do not? I think it deserves some talk about it, because we can confuse recruitment when we are not. Maybe I'm wrong. The bottom line is, if you have severe airway opening pressure, or a closing pressure, again, I'll use the term airway closure and airway opening pressure. I'll just put this back up on screen. I'll use the term airway opening pressure and airway closure sort of interchangeably a lot of the time, because airway closure, your airways would close if your PEEP was too low during exhalation, and then there's a pressure that's required to open them on the way up. So if I say AOP, or airway opening pressure, or airway closure, I'm talking about the same thing. So when you have severe airway closure at a high level, when you're ventilating somebody, the pressure before the airways open. So when I'm talking about airway opening pressure, I'm actually talking about a nice little graphic. Let me just bring it up on the screen because it's much easier. Airway closure. Let me find it. So Dr. Chen, who I had on Friday, is the author of the paper I'm going to look at. And there's actually another article questioning, could it be more harmful than atelectasis in intensive care? But anyways, let me find this. Here we go. Let me share it. Okay, so there's a correspondence, airway closure and acute respiratory distress syndrome, an underestimated and misinterpreted phenomenon. So this letter was written prior to the recruitment to inflation ratio study being published, because they were finding this during the study. So he wrote this letter to describe what he saw. And I'm just going to go to the graphic. So doing slow flow inflation curves, many people are used to seeing graphics like this. And when they see this, they go, that's the lower inflection point. And they say, that's when the lungs recruit. And so that would imply that air is entering the lungs and you're slowly maybe opening up some alveoli, maybe opening up some, and then all of a sudden the lung is now considered open. So many people who consider pressure volume curves as a way to, ventilate an open lung, they want to get past this point, and then they'll try to come down and find the closing, sort of the lower, or the inflection point of closure. So they'll try to recruit the lung and then get to a PEEP that keeps the lung open. The problem is, what they did is they took a ventilator circuit. So this is the red line for circuit. They took the ventilator circuit, completely occluded, and plotted out a pressure volume curve of a blocked circuit. And when you overlay the blocked circuit onto this patient, you see that up until that point, it's as though you're ventilating a completely blocked circuit. So this is not even in the lungs. It's in the airways, the circuit. It's literally, there's nothing expanding the lung at all from here to here. Once you go beyond that point, you're expanding the lungs. So let's say your plateau pressure in this example, let's say it was 25 when ventilating the patient, and you were on a PEEP in this example of 0, which you would never do. But let's say you were. Your driving pressure would be 0 to 25 if this was your plateau pressure, right? But in actuality, if this closing pressure was 16 and your plateau was 25, then your driving pressure is actually 9. That the driving pressure reaching the lung, I should say. But does that mean that this is not injurious? Because a driving pressure of 25 sounds really, really bad. And the answer is yes, it's still injurious, but it's not injurious to the same way we think of distending a lung. So the 15, this actual, 9 centimeters of water would be the driving pressure that could affect the lungs. But this pressure they feel could actually be impacting the airways and causing airway damage because of the amount of pressure that's being forced breath by breath for airways that are not open. So it's not like resistance where you have pressure, but there's still some release of that volume. This is not release until you reach the opening pressure. So that's the potential for why they say, even though this isn't recruiting, they say you should still set your PEEP above this level. And then what they do in this example is they increase PEEP. You can see now it's higher. There's still some airway closure here. There's still that inflection point. Once you get to a PEEP above the level of airway closure, you have a nice linear pressure volume curve. So in the graphic that I shared the other day, let me see if I still have it in my downloads folder. I do. Let me just share this picture now. So in this picture here, let me just add to the stream. This is a slow flow. So this is not a pressure volume curve, but all you have to do is put someone on volume assist control. There's videos on rtmaven.com, which I'm going to throw this up here. I should advertise our blog more often, but our blog is comv.ca. I say our blog, the blog that I'm the editor for the Center of Excellence. And on that site, there's a link to my online calculator that has all the videos on how to do these maneuvers. But basically, all they're doing here is putting the patient in volume assist control. Again, very sedated and paralyzed patient, because no one would actually tolerate this. You put the flow in a servo U. You have to set your eye time to get a flow of 5 liters per minute. In this example, they're using 7 liters. That's fine. As long as it's less than 9 liters per minute, you'll eliminate resistive pressure. And then they fill the lungs slowly with 7 liters per minute of flow. And you can see a very rapid increase in pressure here. And prior to that, you see there's actually there's not even artifact in this pressure compared to above this threshold. So you can see little fluctuations. This could be alveoli recruiting. Sometimes you can see cardiac oscillations, but there's really no artifacts here compared to this line here. So this is a pressure time curve, whereas what I showed you a moment ago was a pressure volume curve. They are arranged differently, but if you arranged, this is flow, this is volume, but this is all over time. So a pressure time curve is a difference. So you just have to imagine this is that inflection point I showed you. So if you drew the circuit on here, it'd be a red line going this way. So they're just kind of inverted in terms of how you have to understand them. But basically, the pressure up until this point is not actually reaching the lung at all. It's this pressure is what's going into the lung here. So whatever, this is 18, and then whatever your end pressure, which looks like the peak is here, is 34 is the peak. That it's not the plateau, but anyways, this is the pressure I would say the true driving pressure, but this pressure matters. So I again, in terms of potential airway damage. So where it's confusing is that, let's say you were doing a decremental PEEP trial. Once you got below a PEEP of 18, your compliance would start to get worse. And that's fine. It would actually prompt you to set PEEP higher than that. So despite airway closure being very important to measure, if you do other things that assess the patient's response to your changes, you're probably going to end up in the same sort of ballpark of where you need to be to overcome this. What I mean by that is that, Ariel, you've said many times before that you like to set PEEP according to driving pressure. Well, if you increased PEEP on this patient, you would see that the driving pressure would continue to reduce, because all you're doing is getting closer from the point at which, and let me just go back to my other screen here. Oh, where am I going here? Let's add it to the stream. There we go. What you're doing is you're increasing PEEP here. So your driving pressure is going to reduce, because this part of the curve is not changing really. It's this part is you're getting less and less pressure from where your PEEP is to where you actually have the opening pressure. So as you increase PEEP, your driving pressure is reducing. Why? Because you're on an exponential curve in this direction. A different thing happens when you're on a high level of PEEP, for example. and you increase PEEP and you have an upper inflection point, then you end up with an exponential increase in pressure when you go too high. But here you have an exponential decrease in pressure as you go up. So your driving pressure is going to come down quite drastically as you increase your PEEP. So just paying close attention to that. If you see as you're reducing or increasing PEEP, your driving pressure changes significantly, which you could argue 5 centimeters of water would be a very significant change, then you need to consider that. If your driving pressure goes up by 5 centimeters of water, that's probably bad. If it goes down by 5 centimeters of water, that's probably good. And there's evidence to suggest that that is associated with better outcomes when your driving pressure is reduced by 5 centimeters of water, and an association with bad outcomes if it increases by 5 centimeters of water. That study is still online ahead of print. Again, one of the studies I probably should discuss in one of my live sessions. So I hope that kind of clarifies driving pressure and how it can be confusing in the presence of airway opening pressure. So just know that if your driving pressure is really high and you have airway opening pressure, the driving pressure that's reaching the lung is actually going to be no different when you increase your PEEP. It's still the same driving pressure reaching the lung, but you're not now sending that pressure to the airways. And then the other thing to consider, I'm on the learning curve. Hopefully I'm recruiting neurons. The other thing to consider is that airway opening pressure may not be completely uniform throughout the lung. So there's a couple of papers. There's the one paper in particular that actually did pressure volume curves, again, slow flow inflation curves to look for airway closure. And they actually tested lungs individually by intubating one lung and then intubating the other lung and checking for airway closure. And one lung had significantly higher airway closure than the other lung. But when they did the maneuver with both lungs, it actually showed a low level of airway closure. Again, pointing out how heterogeneous lungs can be. But what was interesting is when they used EIT to set an optimal PEEP level based on the crossing point between overdistension and collapse, they found that EIT chose the PEEP level that best reflected the highest level of airway opening pressure when they isolated the lungs. So again, because one lung would have lost compliance significantly when the PEEP went below the airway opening pressure. But you can't see one lung when you're adjusting your ventilator. You need EIT to see one lung over the other. So another interesting use for EIT would be to distinguish an optimal PEEP in a patient that has airway opening pressure, but that airway opening pressure that's not uniform. I would imagine that the patient in the image that I shared that Troy sent me, I would argue that that patient probably has some pretty uniform airway closure because it's so high using a global measure of just an endotracheal tube in, ventilating 2 lungs. When it's really low and someone has ARDS, it doesn't imply they don't have any airway closure. They could just have it, but in a different area of the lung that's not being registered by the global measure that we have. But yeah. This one here, the fact that it's so high tells me it's pretty diffuse airway closure. So I hope that adds some fun, exciting thoughts to everyone. Something to think about. And actually, Dr. Chen, if I'm not sure if you watched the broadcast from last Friday, but Dr. Chen talked about airway opening pressure and the importance as well. Let's see. So AOP represents, I'm translating your autocorrect here, Ariel. So AOP represents the average of the air opening in the lungs, right? So I don't even want to say average because in the paper I was referring to, when they isolated one lung, it was around like 4 or 5. And when they did it globally, it was 4 or 5. But when they isolated one lung, it was like 17 in some of the patients. So I wouldn't even say it's an average. I would say that it's because so much of the lung is so open, that lung would continue to expand. So you're not going to see the severity of airway closure in a lung if it's a lot higher than the rest of the lung. The other lung is just going to it's going to be very difficult to interpret curve because that lung will just continue to expand, right? Until there's overdistension. The area that finally opens, you may see a minor fluctuation in the pressure volume curve, but it's not going to appear as airway opening pressure like it was. So it's not an average. I wouldn't call it that, just based on the paper. And I think the paper was 7 or 8 patients, but it definitely was not an average because usually one lung would be quite high and the global would be quite low And it would be, the global would be very similar to the isolated lung that did not have airway closure or significant airway closure. We'll have to watch it. I'm checking patients and listening to you in the background. Pay attention. Pay attention to what you're doing. Don't worry about me. Don't worry about what I'm saying. Yeah, in Dr. Chen's guest visit with me, he talked a lot about some of the data he has from years of collecting data on the ARDS patients using a registry form, using esophageal pressure, transpulmonary pressure, and it was actually quite fascinating how important he found driving pressure to be in terms of association with outcomes. And what's interesting is he actually looked at the true driving pressure, so plateau pressure minus total PEEP. So in all of the work that was done by Marcelo Amato, the paper that was published on driving pressure in New England Journal of Medicine in 2015, they used the driving pressure of 15. They found driving pressure of 15 as the threshold for increased risk of mortality versus less risk of mortality. But they used plateau minus set PEEP because not every study that they used in the analysis had total PEEP measured. But in Lou's, Dr. Chen's registry data, he has total PEEP. So his threshold, he found 15 to be a very good threshold, but it was of total PEEP. So that was interesting because it obviously makes sense. And that would also make sense because someone with airway closure probably wouldn't have, if you measured total PEEP, if you did an expiratory hold, you may see that there's trapped pressure in the lung as well. So an expiratory hold can identify a problem with airway closure, but it's not always exactly the same level. And I believe this is discussed in a paper. Is it discussed in? It might be hold on. Is it discussed in Lou's paper? I know I've seen graphics. I'm just trying to think if it's in the recruitment to inflation ratio paper. It might be in the supplemental data. I won't get into that now. This may be a whole nother discussion. All right, if there's no more questions, I will wait 30 seconds for a question to come in after I say this because there's usually a delay when I ask that. So if there are any more questions, I'll continue. If not, I'm going to sign off and I'm going to schedule another talk for this week. I'll drink coffee while I wait. It's cold now, but it's still good. You're welcome, Joyce. I'm going to be a typical, I don't want to say, you're welcome, Lori, like a typical YouTuber or something, but I should say like, share, subscribe. I made that banner just so I could feel like one of the cool kids. Yeah, if you are watching this, please give it a like. You don't have to share it. You can share it if you want. I think it's public, so it can be shared. But I'm actually also streaming this now to YouTube. So if you're not a fan of Facebook and you come on here and you're like, oh, I really hate Facebook. Like I would much rather watch something like this on YouTube. That's just me. So I am streaming this to YouTube right now live on my Resp Resource channel. So if you searched YouTube for Resp Resource, I think it's youtube.com/Resp Resource, which is that there. You should be able to find my YouTube channel. But if you like Facebook, or you prefer Facebook, no problem. We should do live graphic analysis. You mean like a video or pictures? I'm more than happy to discuss waveforms if people want to send them to me. So Troy sent me that picture that I shared earlier. I'm more than happy to discuss graphics on the I'm going to start calling it the show now that I'm professional with these little thingies. If I get some pictures, we can talk about them on the show. Pics, yeah, pictures. Videos are cool too. I can play videos actually. I can actually play videos from my computer. And I can actually play them without uploading them or without them even being on the internet. But I can also play YouTube videos if anybody has one on YouTube that they want to share. All right. I don't see any more questions. That should be great too. Yeah, it'll be fun. If somebody sends me some, then I'll consider talking about them. All right. I'm going to end the broadcast. It's been 1 hour and 14 minutes that I've been live. Thank you very much for watching. Take care, everyone. Everyone stay safe and look out for my next scheduled live. Now, the scheduled lives are ones that actually have, I'm going to schedule ones that I have a purpose for. Doesn't mean I'm not going to come on live. When I'm bored, I'm going to come on live and it'll just be a Q&A when I come on live. I'm only going to schedule things that I'm going to have a specific topic. Like tonight was that paper. So I'm going to discuss another paper probably in a couple of days. But I'm more than happy to come on prior to that and do Q&A and even waveform analysis. Like I'll just say, hey, I'm coming on tonight for waveform analysis or whatever. Or I might just show up, but I will probably try to make them at 8 o'clock because I did a poll and asked people what time it was on. It's still on my Facebook page. There's a poll asking what time works best for everybody. And I think I gave options of 5, 6, 7, and 8 p.m. And most people selected 8 p.m. I should clarify that's Eastern time because I'm in Eastern time. So thank you very much. Have a great night and stay safe. Bye-bye.